Assalamu alaikum everyone and good afternoon. It's to this post-lunch session. So we will be talking a bit about actinium-225 PSMA therapy, what are the updates and where we are moving. Just to know what alpha emitters are available, this is just, thank you very much. Okay. So do we have the Thank you. So just a list of the alpha emitters that are available for therapy, and it's still missing out some of the alpha emitters, but I've highlighted actinium-225 because this is going to be the focus of my talk. This is just one of my favorite slides that shows the different alpha beta mixed emitters available for the imaging and for radionuclide therapy purposes, and it does include actinium-225, which is a mixed alpha and gamma emitter. Why alpha therapy? We know that the prostate cancer is probably the 5th most common cancer causing deaths in the male population, and particularly in our region, when the prostate cancer patient is diagnosed, it is in the advanced stage. So they have very limited options. They do not have the option for the curative treatment, rather a palliative treatment or just to increase the survival. This is the aim of the treatment. So actinium-225, like many other drugs, is under investigation where we can actually use it with minimum toxicity and maintain the quality of life. And can we add some years to the life, like Professor Hussain yesterday mentioned. So on this particular slide, I would like to have your attention to these two things only. The particle energy, the alpha has 5 to 9 MeV. On the other hand, beta has 50 to 2.3 keV only. And the other thing is linear energy transfer. The range is 80 keV per micron meter, while the beta will travel to longer distance before it is completely destroyed. So it will travel to mm range, and the alpha will travel only in the micrometer range. These are the two most important things on this slide that we need to remember why we need to adopt an alpha therapy as compared to the beta therapy, because we want to kill the tumor cells and not the normal tissue outside the tumor cells. So this is the range of the alpha, and we'll have more double strand killing as compared to the beta here. So how it happens? The alpha, while traveling, it deposits 80 keV per micron meter if we are talking about the actinium, and it has another alpha particle which is around 8 MeV, and it will travel to around 85 micron meter, and the tumor cell has a volume of around 16 micrometers. So before it goes out of the tumor cells, the alpha particle will be completely annihilated, depositing its energy and killing the tumor cells. This is what we want. We don't want the tumor cells, the alpha particles, to go outside the tumor cells and destroy the normal surrounding tissue. This is also a very important slide, and I would like to have your attention on the actinium here on the yellow box, which says the half-life is around 10 days. It converts into francium, which converts into astatine, and then it converts into bismuth. Now from actinium to bismuth, it usually takes 9 to 10 days to decay slowly, but remember, one nucleus which has been converted from actinium to francium, it will quickly go to astatine, and then it will be converting into bismuth. Now during this path, 3 alpha particles will be released. So you can understand that not the single alpha particle will cause the tumor cell death. It will be 3 alpha particles available in a very short period of time that will be killing the tumor cells. So you are going to get a very high damage to the DNA in the tumor cells, causing immediate cell death as compared to the beta cells. On the other hand, this bismuth will take around 45 minutes to go to the next level. So this bismuth is not going to stay connected with the PSMA, it will be released from the PSMA, and now this bismuth is being excreted through the kidneys in the urine, and this is going to reside in the kidneys for some time. So this is going to be a problem because we must know how to get rid of bismuth quickly in order to prevent damage to the kidney tissue here. The two other things that I would like your attention is that there are two gamma being emitted during this path. One is 218 keV and another one is 440 keV. So you can use actinium-225 if you have administered to the patient. You can use these two gamma for the imaging as well and see the biodistribution. Now the alpha decay recoil energy is another phenomenon. Once the alpha decays, the daughter still has some energy left, which is the kinetic converted to the kinetic energy, and the daughter travels to some distance before it is completely destroyed. So the damage to the surrounding tissue. So the crossfire effect, which was much more with the beta, is relatively less with the alpha particles, but it is still there because of this phenomenon. Now, how to prevent the effect on the normal tissues? We have to think of certain things. Now, what happens is that once the actinium is labeled with the PSMA, it goes into the tumor cells, it stays there for some time. During this, it decays from actinium to bismuth, and bismuth goes out of the cells and goes into the kidneys where it resides for some time, and it may cause damage to the kidney tissue here. How can this be prevented? Now, very recently we have publications which says that protein binders can be added, which actually increases the transit time from the plasma to the kidneys. So there will be more time interval for which the labeled actinium PSMA will stay within the plasma and will be available to the tumor cells rather than going to the kidney. So this is how the kidney damage can be actually reduced, and the overall bioavailability to the tumor cells can be increased. The other problem is heterogeneity. We already know, and Professor Hoffman very rightly mentioned it, and he displayed it in one of the ESMO conferences, and we have also followed that we have found that some of them, the tumor tissue are actually FDG avid and not PSMA avid. So how actinium PSMA can help in these cases as well? So actinium PSMA has two more effects to offer. One is bystander effect and the other is antivascular effect. Now, bystander effect is simply because the tumor cells, once they get destroyed, they release some certain signals which are going to the nearby tumor cells which have not accumulated actinium PSMA already. So this chemical signaling is going to cause death in those cells. So this is the bystander effect. The antivascular effect is that the actinium-225 alpha particles which are being released in the tumor cells, the energy is deposited, and the new vascular tissue which has a high proliferation index, the cells are more prone to get damaged by the surrounding radiation. So the minimum energy deposited to these vessels, it gets destroyed, and the tumor cells are deprived of the food and nutrients, so they start the death process starts in those cells as well. So these two will affect the cells which are not accumulating PSMA because they have become non-avid during the course of the disease. So this is how the actinium-225 PSMA can help in those patients who have developed heterogeneity. They are not accumulating PSMA directly, but some of the cells they are accumulating, so the nearby which are not accumulating will be destroyed. Just to explain the bystander effects, so if you collect few people in one place, maybe half of them are quite depressed and half of them are happy. The depressed people will start sending signals to the happy people, and ultimately all of them, they become depressed. So this is the kind of bystander effect that you have. The tumor cells which are being damaged by the alpha, they start releasing cytokines, the energy, and they transfer that energy to the nearby happy cells or the tumor cells, and they get destroyed. So this is the kind of bystander effect. I think now it is more clear with this example. So the first clinical application was back in 2016, and they used actinium PSMA in 2 patients, and 4 cycles were given to each patient, and with very good therapeutic response. With this, they were actually able to display that actinium PSMA can be used without much toxicity. But this was only 2 patients. From there, the group of Dr. Mike Satigi in Pretoria, he actually published this article using actinium PSMA in 14 patients. This was a retrospective study. They were all heavily treated patients, and they failed lutetium PSMA as well. They were all enrolled on the basis of compassionate basis, but the dosing was different in different groups. They applied 200 megabecquerel per kilogram, 150 and 100, and they wanted to look at the efficacy as well as the toxicity. So this is a busy slide, and this I tried to pull up the data published till mid of 2024, and I actually tried to have patients which were 2 cases on one hand and up to more than 70 cases published in another series. So here you can see that the practice has been quite variable. Some of the people, they have used fixed doses like 100 kilobecquerels per kg. Others have used doses much lower than that. 4 megabecquerel was given. Also, they have included patients who were pre-treated with the chemotherapy, and other groups have included chemo-naive patients as well. But look at the bottom line here, the pooled data, which was more than 200 patients. It shows that despite the heterogeneity, the PSA decline more than 50% was in 87% of the patients. So a good number of patients who have been heavily pre-treated, they were not made part of the study as prospective trial, rather than a retrospective analysis was done. And this was 87% patients having more than 50% PSA decline. They also used imaging. Some of them used PSMA PET-CT, others have used bone scan, CT scan to evaluate, and they found that the overall imaging response in terms of complete response and partial response was around 50%. So clinical indications and patient selection remains open until now. Until now, there are no clinical guidelines available for the selection of actinium-225 patients, but we can choose the patient who have been treated with the chemotherapy, with the RLT, and they have progressed or not responded, so they can be included in your trials under discussion with the MDT. So it's not actinium is still not approved for the clinical use. I will not go into the details of all those trials, but the thing is that now some of the trials, they are including hormone sensitive. Some of the trials, they are started including the patients who have not been treated with lutetium. So the applications for the clinical use of actinium PSMA in these patients has been broadened. But all these are under phase 1 or phase 2 trials. The other thing is about the dose and the schedule of giving the therapy. The dose usually is in the range of from 4 megabecquerel to 16 megabecquerel to the patient, or if you are adopting a weight-based model, then from 100 kilobecquerels per kg to 200 kilobecquerels per kg. So there is a broad range, and still no single method has been devised as compared to the one that we already have for lutetium. So these trials which are being mentioned here, they have certain criteria which patients can be included and which has to be excluded. The exclusion criteria is quite, it's quite common in all these trials. They exclude the diffuse bone marrow infiltrations, the patient who have poor PSMA expression on imaging, or they have myelotoxic therapy very recently, or the patients who have some other comorbidities. I have 2 minutes more? Okay, thank you. So administration protocols and dosimetry still under investigation. The tandem therapy is another way of using actinium and lutetium together. The lutetium cycles are given first. If the patient is not responding, then another cycle of lutetium followed by actinium cycle within 48 hours is administered, so that improves the overall response in these patients. When to use actinium PSMA? This is the question. So in our population, we can have under the MDT, we can get the approval in those patients who are either not fit for the RLT lutetium PSMA because of some reasons, or they have already received lutetium PSMA and they have now progressed, and we can offer them actinium PSMA. Just to show you the last slide here, and then these are the randomized control trials which we all need to follow on because the results of these trials will set the pace for the use of clinical setting actinium PSMA in future. Thank you very much.